All right, video 6, last one. So this one's just going to be a pretty big summary of everything we talked about. So we've got pulmonary circulation. Begins in the pulmonary trunk, ends in the left atrium. Just acute respiratory distress syndrome. Ends up being poor oxygenation and non-compliant lungs, and therefore they can't protect their own airway at times. And then the big thing that we do for ARDS patients is proning. We looked into the distribution of pulmonary blood flow. We know that gravity has a lot to do with how well you're oxygenating, and that proning can fix that when gravity is working a little too hard on your vessels. We looked at pulmonary vascular resistance. We know that that calculation is your mean arterial pressure divided by your cardiac output. Poussin's law, the water hose, smaller tube, it's going to pump out quicker, and it's also going to not come out as continuously. The lung zones, we know that zone 1 is going to get the least amount of blood flow, zone 3 is going to get the most. And then the determinants of your cardiac output, ventricular preload and afterload, and your myocardial contractility, so how hard the heart is contracting. And then we looked at what's going to happen to your lungs if you have ARDS, looked at some of the things that can cause ARDS, the way that they're going to diagnose ARDS. Remember the Berlin definition of ARDS, that mild, moderate, and severe. The clinical manifestations, so what the typical symptoms are, and the general ways that we are going to treat it. Remember the 5 Ps, that's a big one, and the ARDSnet protocol of mechanical ventilation. And we saw that the proning really does work based on the imaging. So the chest x-ray, you're seeing better aeration, and here you're seeing less infiltrates on the CT scan. And then we looked at the actual ARDSnet protocol itself, the acute onset symptoms that are required for you to undergo the ARDSnet protocol of mechanical ventilation, and what those typical settings are going to look like. Remember, we want to stay around 6 milliliters per kilogram of predicted body weight. We want to keep that pH between 7.3 and 7.45, and we want to keep that plateau pressure under 30. Otherwise, we just want them to ventilate and oxygenate well. And then we looked at all of the reasons for proning a patient, why it's going to be beneficial to them, why you would do it, like what's going on with the patient that you would do it for, contraindications, why you absolutely would not do it. Our role as the respiratory therapist, remember, we've got the airway and we get to say when everyone moves. We looked at an actual checklist that hospitals are using these days. We looked at the rotoprone bed, which is one of the devices used to do mechanical proning for you. And we also looked at some of the things that you can do if you don't have a rotoprone bed. We looked at how effective proning is, how you can assess that. Remember, you're going to want to look at that pre and post of your SpO2, your respiratory rate, your work of breathing, your dyspnea, how well their chest is expanding, and the special considerations, how to avoid skin breakdown, and what positions they should be in, the swimmer's position. And so now here we are. I have only ever proned one patient, and she was a fairly large woman, so our team actually consisted of like 9 people. And she was on a lot of stuff. She was on ECMO, she was on Flowland, she was intubated, and so it took a lot to manage it. She had so many IVs and so many like indwelling catheters in her, but it was a really good learning experience because it's not something you see every day, but it is something you will be expected to be able to handle. And it's really intimidating. Like, you know that this patient is about to go topsy-turvy on you, basically, and so many things can happen to the tube that's quite literally breathing for them. And on top of that, you've got 7 other people that have to listen to you. It was intimidating, but I did get to see firsthand that it was like almost immediate benefits were gained from her being proned. And she had sepsis. She had so many things going on with her. But like you could immediately see that she became slightly more stable hemodynamically, that they did an ABG on her pretty soon after that, and it was already looking a little bit better. So it does show that it for people who seriously there's no other options for them, it does show that proning is helping. And then lastly, just my citations. I had to do a lot more research than I was expecting to for this. I thought I was going to be able to use the books for most everything, but yep, that's it.